Today, we will be discussing the calcium channel blockers and also the drugs in which their activity is in the RAAS system or the renin-angiotensin aldosterone system. But let's start with the calcium channel blockers. They are still included in our vasodilators, but their action, as the name itself says, nag-block sila sa atuang calcium channel so that there will be no calcium influx, because remember, our blood vessels are also considered as muscles, and for them to contract, kailangan pud og calcium. However, if our blood vessels contract, it means there will be constriction in the area wherein our blood flows. So contraction means constriction. Therefore, we block the calcium channel para walay contraction and at the same time walay constriction. Kaya if ang atong blood vessels mag-constrict, it means there will be an increase in the blood pressure. Now, what are the examples of our calcium channel blockers? We only have two here na wala nag-end sa dipin. We have verapamil. Ang pinaka-common sa community is the isopin, and we have the diltiazem. So either the cardizem or dilzem. So the rest class, nag-end na sila sa dipin. Ang pinaka-common yun, in which I know na you know this drug, we have the amlodipine. And the innovator drug in the market is the Norvasc. However, Norvasc is actually expensive compared to other brands of amlodipine. Okay, Janabel. And then, aside from the amlodipine, be familiar with other dipines class. We have the felodipine, isradipine, nicardipine, nifedipine, and nislodipine. Though we have more pa na mga dipines, but anyway, if the drug ends with dipine, they are calcium channel blockers. Now, I believe nicardipine, especially the cardipine, is given parenterally. So, naatay ampule for this, ginagamit for emergency na mga conditions. Okay, and then we have a newer member of the calcium channel blockers. We call it clevidipine. This is again a new calcium channel blocker, but just like the nicardipine, clevidipine is also administered intravenously. So if the drug class is administered intravenously, it means these are drugs reserved for emergency cases. Okay? Now, ang inyong tandaan, calcium channel blockers are classified into two. This is according to their structure. So, naatay non-dihydropyridine. So, mabala na ninyo kayang ilahang name wala nag-end sa dipin. So, again, they are non-dihydropyridine. Now, those that end with dipin, syempre, they are dihydropyridine. So, ilahang structure contains this one, dihydropyridine. So, that is the reason why they end with dipins. Now, what are the uses of our calcium channel blockers? Syempre, antihypertensive, since we are talking about hypertension now. But when we discuss angina and arrhythmia, we can also encounter the calcium channel blockers because they are also used for chest pain and at the same time for arrhythmia. What do you mean by arrhythmia again? Yesterday, I asked you what do you mean by angina? That's chest pain. How about the arrhythmia? Anyone? What's the difference between angina and arrhythmia? Both are conditions sa heart. Okay, very good, Belly. That's irregular heartbeat. When you say arrhythmia, that's irregular heartbeat or abnormal heartbeat. So tama na siya, Quincy. Pag angina, that's chest pain. But pag arrhythmia, it has something to do with the heartbeat. Now, mechanism of action again inhibits the calcium channel so that there will be no calcium influx, meaning dili mo sulod si calcium inside the cell. Para walay contraction, no constriction, and there is no increase in the blood pressure. ARBs and CCB. If you are class, if you're concerned with the drug-to-drug interaction, did I tell you to download Medscape? Wala. Naiingon daw sa inyo hang mag-download mo Medscape?
The first year lang ni ma'am.
Okay, so now since you're taking pharmacology, please download Medscape. We have there an interaction checker. Ilang hapon naka-download mong gud siya sa akong isa ka cellphone nga very slow. So diha sa interaction checker, you will just ilagay nyo lang class yung drug. Unsa nga ARBs na alay. So okay, sa kadaghan sa drugs, we cannot really memorize all the interaction. Irbisartan. How about the CCB? What CCB is that? Amlodipine? Yeah. Nakabutang din rin no interaction found. Pag no interaction found, wala tay interaction ana, so okay ra na siya isabay within the day. Okay? Again, pag-download mo Medscape ha para mas dali sa inyo ha to check whether there is an interaction or wala. Okay? Next, now the dihydropyridines class, katong mga nag-end sa dipine. Again, ang mga nag-end sa dipine, they are classified under the dihydropyridines. They are more selective as vasodilators kesa sa effect nila sa heart. Okay? So muna ang mga dipines class, they are more used for hypertension kasi sa vasodilating effect nila. While the other two, katong mga non-dihydropyridines, the verapamil and diltiazem, they are actually used more for heart conditions like angina or arrhythmia because their action is more on cardiac depressant sila. Mo na ang kalahian nila ha. Manang wala kayo ninyo, ikay ninyo ma-observe na verapamil and diltiazem is used for hypertension. Kasi para sila sa heart condition, specific sa heart ha. Though ang hypertension can lead to heart failure, but then again, mga specific sa heart like angina and arrhythmia, that's the time we use the non-dihydropyridines. Okay? So among the two, verapamil actually has the greatest depressant effect sa heart. So pag mag-inom ang patient of verapamil, it will decrease the heart rate of the patient, like in the case of arrhythmia na paspas kaayo ang heartbeat or heart rate, and also since nag-slow down ang heart rate, it will also decrease the cardiac output. It will decrease the amount of blood na mapump sa heart for a certain time. Next, we have the diltiazem. It has the same mechanism of action and the same group with verapamil, but it has only an intermediate action. So dili ing ato ka effective, dili sila parehas og efficacy ni verapamil. Though this is still effective, mas taas lang yun ang efficacy ni verapamil when it comes to slowing down the heart function. Okay, questions about the CCBs? Anyone? Again, you have your internet now. You can download the Medscape and explore that application. It will be helpful sa inyo ha, especially in your internship or even when you become a registered pharmacist na and then mag-work mo sa mga butika. There will be a lot of people na mag-ask sa inyo ha if pwede ba isabay ang ingani nga tambal sa ingani nga tambal. So sa kadaghan nato class of drugs, understandable na we cannot memorize everything. So, pwede natin siya backupan ng Medscape that comes handy kay naaraman siya sa imuhang cellphone. Okay? So, magdiretso na ta. Let's talk now about the drugs that are inhibitors of the angiotensin. So, angiotensin na ta. Natay tatlo ka klaseng drug under this. We have the ACE inhibitors, those drug that end with pril, like captopril and nalopril and so on. And the drugs that end with sartan, we call them ARBs or angiotensin receptor blockers. And lastly, we have here the renin inhibitor. We only have one drug here, the aliskiren. So kani silang tatlo, actually their action is in the RAAS or the renin angiotensin aldosterone system. Wait lang, let me add a PowerPoint na ay slide niya empty here because I want to discuss the pathway. So wala pa tanahuman sa inyong pathway, wala pa nahuman inyong pathway sa biochem. Let's talk about the RAAS pathway. Wait lang ha, let me connect this. Okay. So please take note, kaya wala na ko na siya gi-appeal sa akong slide. Because when I discuss the RAAS pathway, nagasulat ko ani sa board. Again, we are now sa RAAS. So meaning sa RAAS, renin, angiotensin, aldosterone system. So kani siya nga system class, nag-work ni siya, naani siya kanang stimulus or stimuli. Naay naga-stimulate before fully blown si pathway mag-start og trabaho. So unsa ang mga stimuli that will result to the activation of the system? Number one, you have here, wait lang, listen ako akong pen. If the patient is experiencing decrease in the blood pressure, again, if the patient is experiencing decrease in the blood pressure or the patient is experiencing hypovolemia. What do you mean by hypovolemia? What's the meaning sa hypovolemia, everyone? Anyone? Hypovolemia, kanang decrease in BP. Sabta naman na diretso, no? Pero pag maingon kag hypovolemia, what does it mean? Hypo. What's the meaning sa hypo? Wala, manawag ta. Manawag ta.
Depletion in body fluid. Depletion and volume of body fluid.
Okay, very good. There is decrease in the body fluid, especially sa blood. So, mubaba class ang water sa body. And at the same time, diri na lang ako siya ibutang pag mubaba si sodium sa body. Or that's what we call hyponatremia. Okay? Do not forget how these are classed the stimuli that will activate our RAAS or the renin angiotensin aldosterone system. Either the patient has hypotension or there is hyponatremia, baba tanan ha, there is decrease in sodium in the body and at the same time decrease fluid loss or decrease in fluid water in the body or decrease in the blood volume. Those are the stimuli. Now, kung sa ilang gina-stimulate, they will actually stimulate the kidneys. Remember, class, the one that regulates the blood pressure na long term kay ang kidneys nato. Pag moment to moment like adjustment sa posture, we have the postural baroreflex. Mag-regulate na siya sa blood pressure. Pero pag long term, kidneys yun na siya. So that is the reason why if the patient has uncontrolled hypertension, pwede siya mauwi into kidney failure. Kaya connected yun na sila duha. So again, if there is this stimuli, this will stimulate the kidneys to produce the first substance. We have here the renin. So if you are asked, class, asa na-produce si renin? Kinsay nag-produce kay renin? It's actually the kidneys. Ang kidneys nato na siya in response to a stimulus. So other name, class, for renin, other name lang ni niya, angiotensin racinogenase. Meaning renin is an enzyme. Again, renin class is an enzyme. Now, unsay gamit ani nga enzyme? This enzyme will actually convert angiotensinogen i-convert na niya into angiotensin 1. Remember sa inyong biochem, sa enzyme nga part, enzymes nga part, di ba, pag muingon kag zymogen, they are inactive na enzymes. I hope you can still remember that yung lesson kay Ma'am Cherry. Again, pag muingon kag zymogen, di ba, they are inactive na enzyme. So actually, kana si angiotensinogen, inactive na siya nga substance. Okay? And then, through the enzyme na siya. So, through the use of this another enzyme, ma-activate na siya, mahimo na siya angiotensin 1. By the way, angiotensinogen is produced in the liver. So, I hope, when siya class, our organs are connected with each other. There are chemicals produced by one organ that is important for another organ. So pag mahimo na siya angiotensin 1, this will be further converted into angiotensin 2. So kinsa ang mag-convert sa iyaha sa angiotensin 2? It's the ACE. Or that's what we call the angiotensin converting enzyme. Now, pag mahimo na siya angiotensin 2 class, this chemical substance actually causes vasoconstriction. Meaning, vasoconstrictor na siya. So, unsay mahitabo kung naay vasoconstriction? Syempre, mutaas ang blood pressure. So, kung ang patient class nag-hypotension, mag-react si kidneys, ma-produce si angiotensin 2, ma-solve ang problema. Because again, si angiotensin 2 is a vasoconstrictor that will lead to increase in the blood pressure. And then another effect of angiotensin 2, I hope nakasunod pa ta sa ako ang ginatang sulat diri lang ako sa taas ibutang. Angiotensin 2 will also trigger the adrenal medulla to release aldosterone. So there will be increase in the aldosterone in the body. So that is the reason why this is called the renin angiotensin aldosterone system. So I think atong mga characters in the story kay complete na, but do not forget na ang effect ni aldosterone in the body is mag-increase siya og sodium and water retention. What does it mean? Dili ma-excrete class si sodium ug si water, instead ma-retain sila sa body. Thus, katong problema nato sa start sa ato ang pathway class, nasulbad na. Nasulbad na kay, di ba, pag mag-increase ang BP, pag naana si angiotensin 2, pwede na mag-increase ulit due to the vasoconstriction. Tapos, if the problem is hyponatremia or hypovolemia, through the release of aldosterone, there will be an increase in the sodium and water retention. So the problems now have been resolved. That's the renin-angiotensin aldosterone system. Questions about the system or about the pathway? Anyone? Please take note ha, kay wala na siya sa akong slide. There are things na dili ko ganahan ginabutang sa akong slide. My God. Wala. Nagasinabot ta sa atong pathway. So, ibutang nato ang mga drugs nato karon. Okay, sige. Ibutang nato atong mga drugs. Atay tulo ka klaseng drug. The first one is the renin inhibitor. We have here, butangan na kog ani ha, this is an indication na inhibitor na siya. We have the aliskiren. That's the name of the drug. And then again, we call it renin inhibitor. Kasi if walay renin class, we're talking about antihypertensive agents. So kung walay renin, kana tanan part sa atuang pathway, wala na na. Angiotensinogen will not be converted to angiotensin 1, and angiotensin 1 will not become angiotensin 2. So there will be no vasoconstriction, there will no be increase in the blood pressure, and there is no increase in the release of aldosterone. So walay sodium and water retention that will actually also lead to increase in the blood pressure. Di ba? Pag daghan kay kag sodium of water in the body, pwede pod mo taas imuhang blood pressure. Mabito na ang mga hypertensive na to nga patient, ang ilahang diet kay dapat walay asin. Okay? Next, what's the next drug that we have here? Syempre, dinhi nga part. We have here the ACE. What do you mean by ACE? The angiotensin converting enzyme inhibitors. Mauna sila class ang mga drugs nato that end with pril, like captopril, enalapril, what's pa? Captopril, enalapril, kinapril, ramipril, fosinopril, basta nag-end na silang tanan sa pril. Okay? And what else? We have here si angiotensin 2 class. Syempre na siya iyahang receptor. Before na siya mag-cause og vasoconstriction, syempre kailangan na siya mo-bind sa iyahang receptor. At the same time para mag-increase si aldosterone. So mao na class nga naatay drug, we call them ARBs. Sa meaning sa ARBs, angiotensin. Actually, this is specific. Angiotensin 2 receptor blockers. Okay, angiotensin 2 receptor blockers. And these are the drugs that end sa sartan. So just like losartan, ang pinakasikat sa ilaha, losartan, telmisartan, valsartan, olmesartan, and so on. So kanang mga nag-end sa sartan nato. So mao ni karon class ang mga drugs. So pag inhibit nato again si renin, wala na ni siya diri, so there is no increase in the blood pressure. That's the same thing with the ACE inhibitors. Kasi without the ACE, angiotensin 1 will not be converted to angiotensin 2. And by the way, angiotensin 1 is considered as vasodilator. So, baliktad na silang effect ni angiotensin 2. So, kung maghatag taog ACE, antihypertensive yun siya. Aside sa wala tay angiotensin 2, we'll have more angiotensin 1 in the body that are considered vasodilators. And then lastly, pwede manggod nga naa na si angiotensin 2, so na-release na siya, pero we can block the receptor. Para dili siya makabind sa iyahang receptor, dili siya mag-cause of vasoconstriction, and there will be no increase in the aldosterone. So not forget ha, si aldosterone, ang trabaho ana niya kay mag-retain og sodium and water in the body, causing in the increase in fluid sa atong body, mag-increase pud ang blood volume. So syempre kung mag-increase ang blood volume, mutaas ang pressure kay kailangan manimog dako nga force para mag-flow ang imuhang daghan nga blood. At the same time, too much aldosterone can even cause edema. Because again, there is fluid retention. So pwede na siya mag-accumulate sa different parts sa imuhang body. Most of the time, ang mga naga-edema, syempre, ang kanang naa sa ilahang tiil, magtapok ang water. Okay? Now, questions about this? Anyone? Balay? So, I hope nasabtan ha ato ang raas para remember that pharmacology is the heart and soul of pharmacy. So I hope people too na daghan na mug na ilhan nga drug. Ang ako lang jud ginaampo na mag-duty, mas ma-retain man gud ni sa inyong memory ang mga drugs actually sa duty, kasi you can really see these drugs, ma-encounter gid ninyo sila personally, and that you will also encounter patients na with different conditions, and you can identify nga based sa ilahang drug you'll have a hint unsa ba ilahang condition. So kana lang ako ang problema kay wala mo'y face to face na internship, but nevertheless I hope na namoy na learn sa atong online class sa pharmacology. So let's talk about the ACE inhibitors. What are the things that you need to know about our prils? Most of our ACE inhibitors are prodrugs. So, ganit meaning sa prodrugs? Let's see. What do you mean again by the prodrug?
Kailangan pa siya i-convert ma'am para ma-exert yung ano niya.
Para ma?
Para, wait lang.
Sige, Bisaya lang ko kaya i-Tagalog. Unsa man to?
Kailangan pa siya ma-convert sa body ma'am bago mag-exert ng pharmacological effect niya.
Okay, very good. So, tama po na siya, Belly, and others nga nag-send og answer. They are actually inactive drugs outside. Inactive sila. Pero once na inom mo na to sila, makasulod sila sa body, kailangan sa sila i-metabolize para ma-activate. So pag naa na ilahang metabolite class, that's the time mag-take na sila og pharmacologic action nila. So do not forget that do not forget that meaning of the prodrug. Now take note, our ACE inhibitors are mostly prodrugs except captopril. Kay si captopril class, nili na niya need i-metabolize kasi captopril itself is already active. So pag inom sa patient ana, once na si captopril mag-bind na sa iyang receptor, which is the ACE or the angiotensin converting enzyme, diretso na siya take sa iyang pharmacologic action. Whereas ang uban klase nga ACE inhibitors, kailangan sa gyud sila i-metabolize class, especially sa liver, para once na ma-release ang ilahang metabolite, mao na to ang mag-take og action. So parehas sa enalapril. Inside the body, enalapril will become enalaprilat. Ramipril, another prodrug na ACE inhibitor, inside the body will become ramiprilat. So maula na ang name nila class para for you to know na mauna na iyahang metabolite, mauna na siyang active nga substance. Butangig 80 sa last. Enalaprilat, ramiprilat. Okay? Pero naata class karon in the market, naanatay mga existing drugs nga supposedly metabolite sila, no? Parehas anang enalaprilat. Naatay enalapril daghan sa market, pero naa na pud tay enalaprilat karon. So, nahimo na pud nila ang supposedly metabolite ni enalapril inside the body, and nahimo na nila karon og kanang existing pud nga drug. So it's up to the patient's need na, or the decision of the doctor whether to give the enalapril or to give the enalaprilat. Okay? Again, depende sa needs sa patient. Now, our ACE inhibitors are useful in treating patients with chronic kidney disease. So, pag ang patient gani class is hypertensive, tapos naa siya'y kidney failure, CKD, chronic kidney failure, ACE inhibitor actually is a good choice. Again, a good choice of drug because the ACE inhibitors actually have this another action in which kanang protective siya sa kidneys. It can actually diminish proteinuria, kaya gina-protect man niya ang kidneys nato. So when you say proteinuria, there is protein in the urine. So mao na iyang gina-decrease para Presence of protein in the urine, manggod, is an indication that you have problems with your kidneys. Kay proteins, remember, are macromolecules. They are big molecules and supposedly dili dapat na siya makapass through sa kidneys o maadto sa urine. Kay dako man na siya kung mugamit ka, ang ato ang kidneys diba are filter. So pag nagagamit tag filter katong mga dagko nga substances, supposedly dili na siya makagawas. So kung magkaroon kag protein, like magpa-urinalysis mo no, tapos na nakabutang dito nga na present sa protein, again, that's an indication nga you have problems with your kidneys. So the use of ACE inhibitors can actually protect your kidneys. It can stabilize the renal function. Tapos another thing, ACE inhibitors are actually used also in diabetic patients even in the absence of hypertension. Kung walay hypertension ang patient, naalang siya diabetes, actually there will be times that the doctor will prescribe also the ACE inhibitors. Karon mao na akong assignment sa inyo. Actually naka-prepare na siya diri sa Schoology, because just like the other one katong sa discussion board nato, wait lang, why is thiazide diuretics used for nephrogenic insipidus? Mo na akong sunod nga question. Kailangan ninyo na i-research, why do you think we use ACE inhibitors for diabetes even in the absence of hypertension? Okay? Ayaw mo pag-trust issue sa last time na nag-answer mo ng thiazide for NDI kay na ang answer wala pa ninyo siya gisulat. So kani karon kamo na sad kay gidiscuss naman ako ang mechanism of action ni ACE inhibitors dito sa renin-angiotensin-aldosterone system. Pero you need to research, why do you think we use ACE inhibitors for diabetes even in the absence of hypertension? Okay? And then aside from that, ACE inhibitors are also useful in cardiac failure. Remember, they inhibit the ACE, meaning dili ma-convert si angiotensin 1 to angiotensin 2, and there will be increase in the angiotensin 1, which is considered also vasodilators. So that if the heart pumps class blood, wala kaayoy resistance kay dilated man ang mga blood vessels. So again, ACE inhibitors are also useful in cardiac failure. Now, let's talk about the side effects of this drug. We have here the dry cough. This is a board exam question kay mao gyud na class ang side effect ni ACE inhibitors. Dry cough, kanang ubo na dili productive. So wait lang ha, mabalaan gyud ninyo ang patient ani nga nag-reach na og toxic points sa ACE inhibitor kay magsigig ubo. Actually, the reason is the angiotensin converting enzyme is not really solely found in the kidneys, but they are also found in the bronchioles, and inhibiting this enzyme will lead to the increase in substances like bradykinin and other bronchoconstrictor na mga substances causing the dry cough. So, mao na siya ang reason nga nung naay dry cough ang ato ang mga ACE inhibitors. So, parehas sa ako ang papa tong nagainom pa ni siya, inalapril man tong iyahang tambal dati. So, mo na siya nga constantly pod na siya ubo, at the same time labi na basta mo inom og alcoholic drink, since ano man siya, acute man siya nga, what you call that, chronic o acute drinker man siya. So wala man siya always nagainom, in occasion lang. So remember, di ba, basta acute alcoholism kay enzyme inhibitor man na siya. So dili ma-metabolize ang ACE, magtapok siya sa iyang lawas mo na mag-ubo-ubo na dayon. Okay? And then we have also angioedema here. Ang angioedema, mura na siya og kanang hives bitaw, kanang murag katul-katul ba sa skin na murag kagid in short. Ayan, murag kagid again in short. And that is also due to the release of the like bradykinin and other inflammatory na mga substances in the body due to the inhibition of the angiotensin converting enzyme. Pag naga-dry cough, hayaan lang. Actually, pag dili na class ma-tolerate sa patient ang dry cough, that's the time the doctor will shift and will change the drug to ARBs, angiotensin receptor blockers. So actually, ano gina siya, ang first na ginahatag is ang mga prills, pero again, notorious man gud na siya nga mag-dry cough niya. Ano man gud ang dry cough kanang hassle bitaw siya sa patient. So daghan kayo ang times nga dili na nila mo-tolerate ang ilahang ubo. Mo na siya nga ginailisan na siya og ARBs. Board exam question po na siya class nga kung mag-dry cough ng patient, unsa daw ang ginahatag nga alternative drug. That's the ARBs. Pero daghan og doctors karon nga wala na sila nagahatag og ACE, na diretso na nila og ARBs class. Actually, ACE gyud ang pinakauna kasi namang gud na siya protective ability sa kidneys. Mao gid nang ato ang like habol din hang anong first siya ginahatag. So alternative lang dapat si sartan. Now, did I answer your question, Sarah? Anha pa na to gamiton si ARBs sa pagdili na ma-tolerate ang dry cough. Now, our prills, our ACE inhibitors are actually teratogenic. So they are contraindicated to pregnant women. Kaya makahamper sila sa development sa fetus. Maka-cause sila og abnormalities or deformities. If may dry cough dahil sa gamot pero mawala. Pag may dry cough, yeah, the dry cough for the ACE inhibitors kasi are caused by the release of local mediators that are inflammatory by nature, just like the histamine, the bradykinin, and so on. So mawala na siya basta mag-take sila og antihistamine. Our problem here is dili man gud dapat ta mag-take og antihistamine for a long period of time. Kay ano man pud gud ang antihistamine, na man gud na siya anticholinergic nga activity. So mauga ka class, mauga imong mata, mauga imong hambaba, you have dry mouth, dry eyes, and so on. So mao pud na ang reason din nga instead of giving antihistamine for a long time, isabay sa ilahang tambal, naga-shift na siya sa ARBs. So kamo pod class, mao pod na pag mag-allergy mo, diba? The doctor will not actually prescribe you a lot of antihistamine. Most likely mga 7 kabuok, mga ingana lang siya. Kasi again, na ay anticholinergic nga activity si antihistamines. So maka-dry siya sa body. Okay? Questions? Wala. So the advantage, if you are asked of the advantage of the angiotensin receptor blockers, the sartan over the ACE inhibitors, that's the they don't cause dry cough. Wala na iyahang advantage. So I think that ends our discussion sa antihypertensive drugs. Any question? Anything that you would like to clarify? So wala.